till again, if proper oral hygiene is not maintained, it can lead to periodontitis. So you would have seen in your practice also, some patients, they don't maintain oral hygiene at all after strapping up. So such cases, it's a difficult scenario. So these are the few articles regarding that. So now coming on to the most important portion, the case selection. So before starting, let me ask you, what do you think? Can all cases treated with braces be treated with aligners? What do you think? Can 100% of the cases be done? No. So actually that is the reality what we need to, understand and also make the patients also understand. Because, there's a certain cases you need to be a bit careful when you take it up for an aligner treatment. Because why I am telling it time and again is because, many of my friends, they also practice aligners, but sometimes, that might not be an ideal case for aligners. But the aligner manufacturer, they will be giving too much confidence. Okay, we can do this, no issues, this will come out good. But at the end, the proper result won't be derived. So, the patients who are undergoing aligner treatment, what I've seen is their expectation out of the treatment will be way higher when compared to patients who are undergoing braces. So, if we are not able to meet their expectation at the end of the treatment, definitely as clinicians, we will end up in a sorry state. So, such situation should be avoided at all cost. And rather than depending on a lab to do the case selection, it's always better if we are able to understand up to what extent we can go with aligners in this particular case. Is this fit for an aligner treatment, or is braces better in this particular case? So all this, when a patient comes to you, when a patient is sitting in front of you on the chair, if you're able to discern then and there, it will be always better, and also that will improve your rapport with the patient. So next few slides we'll be discussing about the case selection. So these are few cases where you can go for an aligner treatment without any second thought. So sometimes doctors ask me, doctor, I've never done an aligner treatment in my clinic, which is the best case to start an aligner treatment with? So if given a choice, if you have a spacing case with you, that's a good way to start your aligner treatment with, provided there's no Bolton's discrepancy and all. If it's a normal spacing case, that's a good case to start with, because in few months, in 3 to 4 months, you'll get to see the result. And normal simple spacing cases, there won't be much complicated biomechanics involved. So spacing is a good case to start with. Then mild to moderate open bite, mild to moderate cross bite, and mild to moderate deep bite. So I'm sure at least some of you would be wondering, how do we know if it is mild to moderate? So in the subsequent slides, you will get an answer to that. Then crowding cases. So these are few cases where you can go for an aligner treatment without any second thought. Right? So next few slides. Any amount of mild to moderate. Then again, if it is a severe crowding, that depends on the material you use. There are multi-layered materials and all. So we will discuss about that in the coming slides. So now next few slides we will discuss about various limitations of clear aligners, or various cases you need to be a bit careful when you take it up for aligner treatment. So first is partially erupted teeth or mixed dentition. So let me tell you upfront, mixed dentition is not an absolute contraindication for aligners. We can do. But when you take the case reports of various cases treated with aligners in mixed dentition, one common thing what we see is, there might be, a requirement for rescan in between. Eruption is there, shedding is there. We might need to, trim the aligners in the area where the tooth is erupting. So if at all the patient is not in town, then that is not feasible. So what we recommend is you can do your interceptive and preventive orthodontics in the mixed dentition phase, and once all the permanent teeth is erupted, that is when the savants are erupted, when the patient is around 13 to 14 years of age, you can do it with aligners. Otherwise also in the mixed dentition, if the patient is in town, and if the patient is approachable and we can call the patient anytime to take a rescan if needed, then we can do, no issues. But in a standardized way, what we can tell is it's always better to start an aligner treatment once all the permanent teeth is erupted, because the compliance also will be better at that age when compared to patients at the mixed dentition. Then next one is highly placed canine with less crown height. So the most important point in the success of an aligner treatment is the fit of the aligner. The aligner should seat properly on all the tooth. So in cases like this where the crown surface area is very much less, the aligner is not going to seat onto the tooth. So in such a case, we have to bond a button, make use of elastic, and then pull it down. So the moment you bond a button, it becomes a hybrid approach. It's not exclusively an aligner treatment. So nowadays, all the doctors, we want to give the best result to the patients. So many doctors opt for hybrid approach. So we will discuss about that later also. Then the next one is dilacerated roots. So dilacerated roots, even in case of conventional orthodontics, that is a challenge, because the roots will be curved. So depending on the curvature, the movements we won't be able to plan the movements. Then the next one is severe posterior crossbite or segmental crossbite. So posterior crossbite means, even though we tell that we can obtain arch expansion using aligners, the expansion that is happening in aligners is dentoalveolar. Skeletal expansion is not happening. So any posterior crossbite which has a dental etiology, we can correct it using aligners. But in cases like this where the upper arch hole as a whole is collapsed, we will not be able to correct it. So in such a case, if the patient is if the palatal molds are not fused, you can go for your expanders. Then if it is an adult, you can go for Marpe, Sarpe and all. But if you want a skeletal expansion, aligners are not the ideal way you can look out for. So any doubts in these 4 points? Is it clear? Okay.
How about that mobile deciduous tube?
Mo
Planning for a clear aligner and mixer division.
Hmm.
If we have a mobile tube, how does it happen?
If it is a mobile tube, then we'll get it extracted and we'll take an OPG and see how long will the succedaneous tooth take to erupt. So based on that, we have to plan. And also that is why it's always better to give such cases in increments, like 1 tray, 2 tray, and then wait and watch how.
We can have some spaces.
Yeah, eruption tabs. There's something known as eruption tab. All that we can keep in such a, which will guide the eruption also. So any doubts? So we'll move ahead. So next is open bite beyond 3 mm. So the maximum open bite correction, where we can correct it to an ideal overbite, will be around 3 to 4 mm. So anything beyond that. So in case of conventional orthodontics, there's a whole lot of things we can play with. There is box elastics and all, which will help us to bring it to an ideal overbite. But in cases where there is an open bite of more than 3 to 4 mm, you always need to be a bit careful. Definitely we can bring about an improvement in the current stage, but it will be difficult to bring it to an ideal overbite. Then the next one is skeletal malocclusion or surgical cases. So this is a clear-cut skeletal class 3 case. So even if you were to camouflage a skeletal case, what I have observed is the result what we get with braces is much